myself, Dr. Onai, and Dr. Salvin would like to welcome everybody who's here for our webinar today. The title for today is Cardiac Conversations, Collaborating to Advance Neonatal Care. So we'll discuss how we at Boston Children's Hospital care for the neonate with congenital heart disease, how we integrate care from their fetal life through adulthood, and what we're doing to improve the outcomes of these neonates through the years. So my name is Dr. Kaza. I'm the director of the Neonatal Heart Surgery Program. I'm an associate professor of surgery at Harvard Medical School. And I'll let Dr. Onai and Dr. Salvin introduce themselves.
I'm Dr. Ronay. I'm the associate program director for fetal cardiology. And I take care of patients from prenatal diagnosis through early adulthood.
I'm Dr. Salvin. I'm the chief of the Division of Cardiovascular Critical Care and an associate professor at Harvard Medical School. And I'm in charge of the patients that come through the cardiac intensive care unit from birth all the way through adulthood with congenital heart disease.
I want to thank Dr. Onay and Dr. Salvin for joining us today. Maybe I can start off, Chris, by asking if you can explain to the attendees what kind of care does a newborn with a heart condition need?
I mean, I would say,
and how do you determine the type of care they would need?
I think that's a great question. So, for many of our patients, they have had a prenatal diagnosis in our fetal care center, and we have hopefully made a pretty accurate diagnosis of what type of congenital heart disease they have. And what we talk a lot about during the fetal counseling session is the coordination of care between their OBGYNs, maternal fetal medicine, and how that transitioned from birth at one of our local hospitals in the Longwood area, or if we think they're going to be stable in one of the surrounding hospitals, what their needs might be. And then we talk about how the transfer will be if they were to need surgery or cardiac intervention in the first week or so after birth. And so we spend a lot of time talking about whether or not we think what the best location for delivery would be for the mom and for the baby. And then in addition, if they're going to need certain medications, what the timeliness of echocardiogram would be, what medications might need to be started, and to really try and set everyone up for success for when they arrive in the cardiac ICU. And we sort of transition the care to those intensive care doctors, but also are, following along, reminding everyone about things that we discussed in the fetal period.
If we can get a little granular, say you have a baby out in Western Massachusetts in fetal life, was noted to have tetralogy of Fallot, otherwise favorable anatomy. Is that somebody you would advise to deliver locally, or would you advise them to deliver in Boston versus a baby that has hypoplastic left heart syndrome? How does that differ?
That's a great point. So for our babies with hypoplastic left heart syndrome, who we think are going to need an intervention in the first week of life, those are babies that we work on a shared care model to have them deliver at one of our local institutions, so that they can get started on prostaglandin and transferred to the cardiac ICU and get all of the appropriate preoperative testing done before they would ultimately go to the operating room or the cath lab, depending on what direction that needs to go. In terms of the tetralogy of Fallot patient, I think there's a lot of things that we look at prenatally to decide whether there are patients that would be completely safe to deliver in Western Massachusetts with their local team, and certainly not force those families to deliver out here in Boston when they have a team there that is very, very suitable for taking care of their baby after birth. And so a lot of the things that we look at are, is there any reversal of flow in the ductus arteriosus? So do we think that there's going to be enough antegrade pulmonary blood flow at birth? And will that remain the case as the ductus closes? We look at branch PA size in utero. We look at the direction of the ductus arteriosus. And we measure the pulmonary valve annulus and things like that. And by and large, we have a number of fetal indicators that would let us know what the best location is.
So next question is for Dr. Salvin. Josh, you've been here 3 decades. Can you tell us I know you don't look that old, but over
Close,
your
close,
tenure
yeah.
here, uh, how has care for a baby, say, let's pick a couple of lesions, maybe start with the hypoplastic left heart baby. How has that care evolved in your term here?
Oh, it's a great question. I think we at Boston Children's developed the first real operation or stages of operations for babies with hypoplastic left heart syndrome. And when I started here, there was a 20-bed ICU, which expanded to 24 beds. Uh, and the neonates would come across from wherever they were delivered, typically at Brigham and Women's Hospital with that disease, and we would care for them in the immediate postoperative newborn period. It often involved a heart operation. That heart operation was very standardized and required a very long cardiopulmonary bypass time, often a period of circulatory arrest for the babies, and had a very protracted postoperative course, a complicated protracted postoperative course. During my first, I guess, 10 years here, we underwent a study to look at the types of operations that we were doing and to see if that type of operation could be modified such that would reduce bypass times and potentially reduce the interstage death rate, the complications between the types of operations that needed to happen in the newborn period and the childhood period. And we did modify that type of operation a fair bit. And that was a large multidisciplinary study that encompassed many hospitals, but we were the driver of the outcomes of that study and really informed how we care for patients. So we modified that original first stage neonatal operation and saw that the outcomes early on were better for our patients. So was our approach for the next probably 10 years or so. And I would say in the last 5 to 10 years, we've approached this hypoplastic left heart syndrome a bit differently. And that's because Dr. Renai and her group and the postnatal imaging, the echocardiography team has been able to give us very precise anatomic details of patients. And when we've been able to make much more catered decisions based on anatomic variants that patients have. So whether your aortic valve is a certain size, your mitral valve is a certain size, whether there's connections between the coronary arteries and the ventricle itself, these are things that we couldn't necessarily see as well when I started here. And now with the advancements in imaging, the catheterization procedures, we've been able to really categorize these patients a bit differently, and because of that, we've been able to do procedures that are much less invasive on certain subset of patients. So there still are a set of patients that need to go immediately to the operating room on the first day or two of life, or to have a procedure in the cath lab in the first day or two of life. But many of these patients, we can actually pause, regroup, work with our surgical colleagues, get their expertise, work with our imaging colleagues and our interventional cardiologists, and come up with the plan that's the least invasive and is going to have the most beneficial long-term impact for our patients. For example, some babies don't need this typical heart operation straight out of the gate. We can do an interventional cardiology, a catheter-based procedure that replaces that first stage. And the main impact of that is on our long-term neurologic outcomes. We'd love to avoid cardiopulmonary bypass if possible. It's often not, but if we can, we're very, very careful and very thoughtful about how we approach these patients. So the advances of technology that I've seen over my career at this institution and our ability to innovate based on those advances has really been remarkable. It's been an incredible experience being here.
Oh, that's great, Josh. Just to piggyback on that, just a surgical perspective, I mean, we have an amazing group of surgeons, a dynamic group of surgeons who are thinking about how can we improve the outcomes from the status quo. It used to be that the accepted mortality rate for an organ procedure was 20-30%. But then we started questioning, does it have to be that high? What are the pitfalls of that operation? The aorta is tiny, it's 1 or 2 millimeters. Now, suddenly, about 9 years ago, we decided to enlarge that pathway. So the blood vessels to the heart get more blood. And we've seen remarkable changes in outcomes where there's fewer children with myocardial dysfunction or heart dysfunction with that move. We've changed the type of blood flow we provide the lungs based on the study that Dr. Salvin described. We use what's called an RV to PA shunt. Now we use a valved conduit for the benefit that having a valve would prevent that single ventricle from being volume loaded. So we made lots of advances surgically, but I think the most important thing that Dr. Salvin said was this personalized care. It's not just that one operation fits the baby. We are paying very careful attention to the particular anatomy of that baby and deciding which interventional pathway would provide them with the best outcome in the long. So I think that to me is the biggest advance we made in the last decade is Dr. Renee calls this the personalized care model. You know, how do we take this to the next level? Chris, any comments on that?
Yeah, I mean, I think that certainly in fetal life, that's one of the things that we spend a lot of time talking about is that, you know, this will be an individualized approach within, you know, certain guardrails that we have for each type of congenital heart lesion. And so it can lead to counseling taking a very long time as you're sort of laying out several different options. And this certainly isn't a choose your own adventure, but I think that one of the wonderful things has been is, you know, we've incorporated prenatal surgical consults is the collaboration between the fetal cardiologists and the surgeons about what we think might be the best approach as long as the anatomy looks the same after birth as it did prenatally. And I think that we've really, even in terms of just doing second opinions for some of our families that are not, you know, necessarily local, we've been able to look at images and sort of say, you know, we think with the information we have in front of us, this would probably be the approach we would take if you were to deliver here in Boston and have surgery here.
So Josh, I mean, you know, can you pick up on this collaborative model and how this has helped improve outcomes, not only from the cardiac standpoint, but from a neurologic and the total baby standpoint? What are some of the things you do in the ICU?
Yeah, that's a great question. So the ICU is really the team sport equivalent in the heart within the heart center. So everything that happens in the ICU is a collaboration, and it starts when babies are born next door and come across the bridge. We collaborate with the neonatologists at the Brigham and Women's Hospital in this case. And we collaborate with our neonatal colleagues over here, our neonatology colleagues over here. We review imaging data right away, as I alluded to with our imaging colleagues. We sit down with the surgeons. There's conferences twice a week that we review all the potential surgical cases. But beyond that, every single day, we meet as a group in the ICU with our surgical colleagues and our imaging colleagues to discuss the most high-risk patients, which are our neonatal patients. So that's a focus out of the gate. We'll often, taking one step back, meet families before they even get here. Our nursing leadership will bring families through the ICU, show families what it's like to have a child with a certain disease. We can often find a patient with the same exact heart lesion in the ICU. We could show them what their course will look like, and they can sometimes even meet families early on and connect and learn about that experience. Once the decision is made to move towards the operation, then we collaborate with our anesthesia team. There's formal conversations and handoffs between these groups. And importantly, when patients come back, we do the same thing. The transfer of information is really, really seamless. I can let Dr. Kaza talk a bit about this, but the interoperative approach has evolved as well. The things that we do to protect, particularly the brain and the organs that are very fragile in a baby, have evolved dramatically, and we've adopted new innovations to protect organs in small babies during bypass. And when we come upstairs to the ICU, we continue to do that in the way that we care for patients, the medications we choose. It's all fine-tuned to the exact operation that the baby's had and to the exact situation that the physiology allows. I think it would be remiss if I didn't bring up our surgical, our nursing team, the CICU nursing team. We have 200 specially trained cardiac intensive care nurses. They don't rotate anywhere else in the hospital. They're specific to our patients, and every single one of them has neonatal experience and can take care of our smallest and most vulnerable patients. And the focus of that is to really think about not just how do we heal these babies, but how do we heal them and let them go home to the kind of a normal neurodevelopmental pathway, or as close to normal as possible. So we try to do all the normal baby things that we can within the limitations of the recovery period. But we think about things that sound silly, the sound levels in the ICU, the light levels in the ICU, how we're moving patients around, even when they're quite sick and can't really move, thinking about physical therapy. Those are all considerations that seem small and seem maybe trivial when a baby is very, very ill, but we found them to have a huge impact in the long-term outcomes. And the last piece of this, besides nursing, and you can see some of the subspecialties here. We talked about nursing, neonatology, anesthesia, cardiology, surgery. There's the focus on nutrition has really been an area that's been unique and novel at Boston Children's. We have an entire team dedicated to just the nutrition of neonatal patients, and we're learning a tremendous amount every single day, making huge advancements in our understanding of how important early nutrition and rehabilitation is for our patients in preserving all of the organ systems, but certainly the brain and the neurodevelopmental outcomes.
That's such a great explanation, Josh. When we first started with this neonatal cardiac care consortium, it was 3 or 4 specialties, but then we realized it's multiple specialties. And already you pointed out, we're missing the nutritional aspect of the PECAN team that's headed by Dr. Mills to really, getting these children nutritionally robust means they're able to develop normally. I think your ICU's focus on the nutritional aspects is something that's amiss from this diagram. But I just put this graphic up to show that it really takes a village to help care for these children. It's not just us in surgery, not Dr. Salvin in ICU, Renee in fetal and cardiology care, but it's everybody singularly focused on improving outcomes for every single baby. So even in the 1.5 decade I've been here, I've seen an evolution towards this team-based care. And I can tell you, I strongly believe this. It has improved outcomes for our patients tremendously, not only from the cardiac standpoint, but from a neurodevelopmental standpoint. Now we have this robust screening of the brain before and after surgery to preempt any injury to the brain that could potentially occur with the surgery we do. And we actively treat that. I just want to comment on one thing Dr. Salvin said. How do we protect the brain during surgery? Anytime we do arch repairs or do a Norwood procedure for hypoplastic left heart syndrome, we're always doing a technique where we perfuse the baby's brain, even though technically it's more involved, because we think perfusing the brain and not shutting the circulation off is actually important for the child as he or she grows. So maybe I can go back to Dr. Renee and ask you, how do you think we can improve the care we're providing even more? What are some of the things we can look forward to that'll help us achieve even better outcomes?
Yeah, I think that there's a growing attention being paid to some of the prenatal concerns that can lead to babies being delivered premature. I think that, we work very closely with our maternal fetal medicine and OBGYN colleagues to make sure that we try to deliver these babies as close to term as possible, but sometimes there are indications for earlier delivery. And I think that we are working in terms of, the risk for preeclampsia when there's prenatally diagnosed congenital heart disease, there's a higher incidence of that. And so I think that those collaborations that we have from the prenatal standpoint are really improving. I think similarly, we're paying a lot of attention to the, both maternal and paternal stress that these families have when you get a prenatal diagnosis of congenital heart disease, and trying as much as possible to ensure that families have all the support they need to start what can be both a shorter journey through our cardiac program versus a longer journey, for some of our single ventricle patients. It can be a lot of time in the hospital, and how do you balance that? And so, I think our social work colleagues, do a tremendous amount to sort of support our families, especially if they're coming from far away. And then I think there's the genetics piece as well. I think that, we have a very robust cardiac genetic program here in terms of our prenatal genetic testing, and then the genetic testing that we do after birth, in order to help families understand some of the neurodevelopmental differences that some of our patients do end up having. Some of it obviously is, these children undergo a lot of things in their, critical brain development time, but at the same time, we are finding further, genetic differences that can help explain those neurodevelopmental differences as well.
That's great, Chris. Josh, I know you pioneered a system called T3 that we use in the ICU, which is it's a system that utilizes the baby's hemodynamics to forecast the health of the baby. How do you see using that or any other new artificial intelligence models in the ICU to make our outcomes even better?
Thank you, AK. That's a great question, and I see at the top of the slide here it says data science, and I think that's a huge component of what we've done at Boston Children's. In collaboration with scientists at MIT, we developed this system called T3, which is a web-based system that collects all of the data coming to the baby. And a baby after heart surgery has multiple monitoring devices attached to them. And it could be information overload. It can be information overload if there was a small number of patients, but when you say that there are 20 or 30 neonates at any given time, it's a lot of information coming at the provider team. So this is a system that has allowed that to narrow our focus and really see the important pieces of data that are coming at us. The technology is great, but if you can't utilize it effectively, it's not helpful. And this lets us really target how to utilize the data. We've come up with predictive analytics models that are associated with terrible events like a cardiac arrest that can often, if we pay attention to those, can help us predict those things before they happen, or alert our physicians and nursing teams to be able to put a little bit more attention towards the patient or change the trajectory, and we can ward off some of that. And we've also come up with ways to use these predictive analytics, I think importantly, to de-escalate care so that patients don't remain too long in the ICU, don't remain too long on a ventilator, or too long connected to machines that they may or may not need. And we've shown, Dr. Newberg and others have shown that reducing the time in the ICU is important in improving the long-term neurologic outcomes in the ICU. Every day that you get out of the ICU sooner is a day that you're moving towards real recovery for these really fragile neonatal patients of ours. So the data science has helped us do some practical interventions that change the time that patients have to stay in the ICU. And the last thing I'll say is that this field is wide open, and we continue to partner with our colleagues at across the bridge at Harvard and at MIT, and working on how do we use the data that we have to come up with completely new care models, whether that's around documentation, whether that's around taking complex data and simplifying it so that we can see the real signal in all the noise and the data that we have. And those are projects that are ongoing all the time. And the nice thing about being here is we can take those and very, very rapidly turn them into practical pieces of our practical tools that can positively impact our patients. And it's an exciting time to be part of this.
That's great. Chris, a question for you. I know I've heard this from some families who lament that we've become so big. I mean, we are the largest program in North America, right? That some of the attention, personalized care gets lost in this vast machinery that's our program. I mean, to me, a program like the neonatal group we have, personalized and said, what is your perspective? What would you tell expectant mothers who have babies with congenital heart disease about any questions they may have about are they still going to be able to receive the personalized care they expect, or are they just going to be part of this big kind of program where they're another patient?
I mean, I think that one of the benefits of our program is that, you often have the fetal cardiologist that you meet during prenatal life is frequently the cardiologist that will then follow you through the rest of your journey. And I think that, there are enough of us that I think each of those patients do get that personalized approach, because it's not just one person seeing 800 patients, which would not at all be possible to provide a sort of personalized approach, and you would be in a machine. So I think that the value of, our several fetal cardiologists that meet with these families, and then plugging that into the smaller, sort of neonatal group that gets to meet with the surgeons prenatally, and then is discussed, on neonatal rounds and things like that, means that you actually have a small team that is very, very integral to actually making sure that you are getting personalized personalized medical approach in a big, busy hospital.
Yeah, that's exactly what I tell families. I think we've broken this down into small teams that care for your baby through the continuum. There's going to be that team that cares for your baby when they're in the neonatal period, through the infant toddler thing. Then we have a team who specializes depending on if they want to go to a biventricular conversion. There's a biventricular team that gets a full handoff, or if they have a single ventricle Fontan type operation, we have a team for that. Or as an adult, 20, 30 years down the road, they have something else that needs to be addressed. We have a robust adult congenital program. So, I kind of set you up because I had my own answer for it, which is, I think at least in the neonatal period, we have a consistent team that cares for the baby. So even though it's an enormously large program, your baby is going to have a consistent team that lays their eyes on your baby several times every day, multiple people. So I think to me, that's very important, because that's the cornerstone of the personalized care we're talking about. So maybe one more question for Dr. Salvin, and then we can see if there's questions from the audience. Josh, you're kind of the futurist. So where do you see neonatal care, evolving in 10 years? What are some bold predictions you may have, like 2 or 3 big things?
Yeah. I think that the technology advances that we've seen in the last 4 or 5 years with artificial intelligence have really have potential to make an incredible impact, and that's and the computing power in general have had an impact in our patients. We have surgeons, Dr. Hoganson, for example, is creating 3D models of babies' hearts and able to do incredible things that for us to visualize and see what the heart looks like, so we can plan a very specified particular operation based on not just the subtype of heart disease, but the specific anatomy of a specific baby. And that is, Dr. Kaza can speak to this better than anybody else, that has changed the amount of time that the babies need to spend on bypass, how quickly the surgeon may be able to think about a solution to a problem because they've seen it in a 3D model. And none of that was possible even several years ago, before the computing power has gotten more effective. We've been able to come up with more and more predictive analytics models as we get more information about patients, and we can drill down and look at the historical outcomes for very small subsets of patients and make good decisions about what we would do for the next patient with this disease based on very granular data that we've never been able to utilize before. And with the use of AI, we're actually being able to make predictions and share data in ways that we never have. So I think, to me, it's the technology, it's the data science, it's the computing power, along with the advancements, of course, in the devices and the machines that we use. But those are all interrelated to me.
All right, quickly, Chris, what is your predictions for the next over the next decade in neonatal care? Where are we going to go?
I think we're going to have a much better sense of a lot of the underlying genetic syndromes that, or genetic differences that are able to be picked up prenatally. I think we're going to be able to move more towards knowing that before the baby's born, and not just sending cord blood after birth and waiting for microarrays versus whole exome sequencing. I think there's going to be a huge leap forward in that respect. I think we're also going to be able to do a better job of trying to get our babies delivered as close to term. I think some of the seminal work for that was done both at Boston Children's and at the Brigham, in terms of, the importance of these babies getting as close to 39, 40 weeks as possible. And I think that we're going to be able to support those babies staying in utero for the appropriate amount of time. And so I think those are a lot of the changes. And then I think we're going to get better and better at being able to truly use a lot of what we see prenatally on imaging to try and predict what we think will be the best operative course forward after birth.
Yeah, and from a surgical point, for me, just like Dr. Salvin said, it's this notion of virtual surgery where you're able to do precisely the operation you intend to do on the baby in this computing model. So you work all the kinks out, do it more efficiently without any residual lesions, and protecting the brain and other organ systems. So optimizing perfusion, how we do the heart-lung machine during surgery. So I think it's a very exciting time to be in this field. So maybe we ask Bella or Casey if there's any questions from the audience. I can chat. Okay. None so far. So I have a quick kind of email and a telephone number for any of the audience that wants to contact our team. It's the CV Surgery Coordinators -DL at cardio.chboston.org. And this is our telephone number. But maybe I'll give it another couple of minutes for questions. But in the interim, I want to thank Dr. Renee and Dr. Salvin. I know you guys are extremely busy. And I think Dr. Salvin needs to get to a graduation ceremony in a few minutes. So I can't thank you enough. And I also want to thank Casey and Bella for really organizing this and keeping us on track. So thank you, guys.
Thank you.
Thank you.
Oh, there's a question from a guest. Can you talk a little bit about the neuropsych risks and components connected to congenital heart defects and best practices for evaluation and assessment? Chris, you want to take that?
Sure. I would say that I think, as Dr. Salvin alluded to, we have a whole neurodevelopmental team in terms of nursing staff, psychologists that see our neonates that have undergone cardiac surgery before they leave the hospital. And then we have a wonderful cardiac neurodevelopment team that really follows these patients longitudinally. And so there are intervals where they are assessed. And there are many of our patients that, fly through being an infant, eating, breathing, growing, doing a lot of gross motor things. And then as fine motor skills become more important, sometimes some troubles arise then. And so our neurodevelopment team at Boston Children's actually continues to see these patients longitudinally. So even when you don't even no longer qualify for early intervention because you're doing so well, I feel it's really important that our neurodevelopmental team actually continues to follow those patients and sometimes is really able to help support them as they go into school with IEPs, or if there's just little extra differences that they need extra help with. Our neurodevelopmental team is there in the background supporting them.
Just to another perspective, Michelle, on that question, Dr. Valencia, who is a partner of Dr. Salvin's in ICU, undertook a study where she was studying all these newborns that have had heart surgery with encephalograms and ultrasounds. And interestingly, I mentioned the particular perfusion technique we use or how we run bypass in the OR. We had some of the lowest risks of seizures or strokes after surgery. So that's something we're proud of. But still, like Dr. Ronai said, they need a robust program that continues to screen them for any potential deficits. So, Chris, Josh, thank you very much for your time.
Thank you.
And guests who attended, feel free to contact us if you have any other additional questions. We'll be happy to email you. Thank you very much.